I'm Lieve Peremans. I'm coming from Belgium, from the University of Antwerp. In fact, it's the work of my PhD student and from some master students. And my PhD student said, "Oh no, I'm going to be on holidays. Would you please present this work?" So I will present the work of all these people, and it's a contextual analysis prior to the implementation of an evidence-based complex intervention for primary prevention of cardiovascular disease at primary healthcare and community level. It's a descriptive qualitative study using adaptive framework analysis. I said you could make a more easier title for me, please. So this project is part of a very large project, a Horizon 2020 project, which is called SPICES. And SPICES is a scaling up of packages of interventions for cardiovascular disease prevention in selected sites in Europe and in sub-Saharan Africa. And it's done with the University of Brest in France, with United Kingdom, with Uganda, and with South Africa. And the SPICES site in Belgium has a double aim. First of all, the most important aim is to implement an evidence-based complex intervention for primary prevention of cardiovascular disease. But we want also to know the context in which we want to work. We have to do first the context analysis before we can do a complex intervention. And we did this analysis on macro, meso, and micro level. But now I'm going to present you the part on the micro level. Actually, the study on the evidence of the intervention has also already been done. So we are now on the moment of starting the complex intervention. But this is what is happening on micro level. Well, the problem where we start from is that you know, the number one of cause of mortality and morbidity are cardiovascular diseases for the moment in Europe. And there is a big problem because there is a lot of unawareness around the people about their cardiovascular risk profile, because there is an asymptomatic course of a lot of these cardiovascular diseases. And we also know that the primary prevention is important. Changing your lifestyle and taking a healthy lifestyle saves lives. Where are we going to do this study? We are going to do this study in a urban setting in Antwerp, and a setting where there are living a lot of people with a low socio-economic status. So these are really very vulnerable people with an increased cardiovascular disease risk. There are also a lot of migrants in this region, but we start first with the people from the Belgian or the autochthone origin, and then we will go further on with the migrants, because it's not easy to develop the tools for them. So it's a multi-phased problem, because these people have no GP or don't find the way to healthcare. So there is a very low coverage of health promotion in this group of people. And in fact, in our country, we have not these nice big primary healthcare centers where there are systematic initiatives for primary prevention. We have a lot of single-handed practices with GPs who are really overburdened, and we have in these regions also a shortage of GPs. There are also welfare organizations, but there is not enough collaboration between primary healthcare and this welfare organization. For the moment, little is known about the way the primary healthcare practices organize this prevention. Some of them do, but most of them not. The current role and tasks of prevention from the nurses in the primary healthcare practices, and the possible role of the welfare workers on raising the awareness of vulnerable people. Which kind of role might they have in this whole um, intervention? So first of all, there were three aims. So we want to map the current situation in concerning the behavior change within primary prevention on community level and the impact of the primary healthcare providers on that. Second, we want to specify the role of the practice nurses. And third, we want also to look at the future role of the welfare workers. So SPICES is a participatory action research and it's in a transformative research paradigm, which means we start from inequity and we want to change and to empower these people to take their own health in their hands and doing something with it together with professionals and welfare workers. So this is a contextual analysis, and for this contextual analysis we used a descriptive qualitative design, and we have in fact three study parts on the micro level. So we want to have a stakeholder mapping, and we were looking which kind of practices and welfare organizations were working in this region of the city of Antwerp. And this was a little bit disappointing because we only have one practice in that region who has a practice nurse and with an integrated profile. And we have one practice who was collaborated with a practice nurse, but just on an instrumental level. So we have not so many opportunities over there. And we also looked at other practices who have practice nurses, but not in that region, to see what might be the potential of these practice nurses. And then the third part, we looked at the welfare workers in that region and see what they could mean for our project. Because all these issues are extremely important for the sustainability of the project afterwards. If we are not looking what capacity there is in a region, there is no chance to have sustainability for this kind of projects. So we used, to make our topic guide, we used the consolidated framework for implementation research, the normalization process theory, and also a consortium consensus on developing the topic guideline. We want to have a description of the organization, of the setting, of the current practices that people are doing, and on the opportunities and challenges. For credibility check, we had three researchers with a different background, independent from each other, and we did a peer debriefing with the senior research team. And for the analysis, we used an adaptive framework analysis based on the same theories and frameworks we also used for developing the topic guideline. So we did a thematic analysis and with charting the themes in the adaptive framework. This is the adaptive framework. I'm aware because it's from the consolidated framework of implementation research. It's not the global model because it was too complicated, and we reduced it we adapt this framework for doing the analysis. So you see, we use 4 domains: the intervention characteristics, the inner setting, describing of the outer setting, and the characteristics of the individuals. First of all, let us focus on the intervention, and I take out a few quotes and a few highlights. It's impossible to focus on everything. For instance, we look at the quality, what was important on the primary healthcare level. So when we did the interviews in the general practices, so there was a need for evidence-based tools. You had a lot of mHealth tools, a lot of apps, but they need to be underpinned, they need to be evidence-based. So it could be a relative advantage for vulnerable people, but there is also some critics on it, because not all these people have the skilled health literacy to use these apps, and some of them will help it, other ones will have nothing on it. But group counseling, like we see already in other projects, groups might help because the dynamics are very important. The cost is another barrier because it's only feasible in a capitation system, and we have not so many practices with a capitation system. We only have one in that region. On the community level, they see the welfare workers, they see a lot of advantages. They say we have a high accessibility for these vulnerable people. We see them for social issues. We can talk to them. We can mobilize them to do something on their health. And they said, you have a very good tool. You have the inte tool, which is on a tablet, and we can use that to make a profiling from these people and to send them to the right healthcare provider, or to, for instance, a coach to start to move, because we have that, coaches to start to move. So they said, yes, it's a collective action, but we have to adapt it to each small part of this district. So we have to adapt the interventions at the context, at the local context. Here also the cost might be a barrier, because the supervisors of these welfare workers, they said, we need the time to do that, and time is money. If we look at the inner setting, you see that it's important that practices have the right mission and vision, that they want to take up this primary prevention, and also that the nurses which might work in this practice, because some of the practices will have a nurse in the future, they need to have an integrated profile. So that means that they really can do things on primary prevention. It's also a collective action, so the whole practice needs to be behind this thing. If we look at the outer setting, we see also we are focused on patient needs and resources and cosmopolitanism. So if we look at the first one, it's important that these practices have more connection with the welfare organizations in their neighborhood. There are not so many connections for the moment, so this needs to be strengthened. The patient needs and resources, so GPs have difficulties to reach these vulnerable people, and on the other hand, it's not at the agenda of the poor people. They want to survive. They want to have food, and they said they don't take efforts to cook for themselves, so we will need to have interventions where we are going to cook with them together, or to make healthy meals or so. On the last point, we look at the characteristics of the individuals, and everybody says the GPs, the practice nurses, and the welfare workers, we need specific trainings for that. We need to refresh our trainings on communication. We need motivational interviewing. We need to know the techniques of behavior change. And that's important because it's a difficult population, and it needs a lot of skills to overcome the barriers from these people to step in a project on primary prevention. The strength of this study is that we used a theoretical framework, so that the work we have done might be transferable for other regions. We use different techniques and perspectives, and we use also peer review. The limitations were that the interviewers were quite young, and there were nurses and GPs, and that actually we have not so many practices, but that will be also a limitation for the future, for the implementation. So we have a comprehensive sample. Practice nurses can play an important role in primary prevention, but there are some conditions. The vision and the mission of the practices need to be clear and need to accept an integrative role of this nurse. We need, in fact, practices with a capitation system, because when you have a fee for payment, then it's very difficult to do primary prevention because GPs are not paid for that. And we need training of motivational interviewing. Welfare workers are in a good position to reach these vulnerable people in the community, but we need train-the-trainer sessions, which actually are started for the moment. We need a well-developed and scientific sound tools, easy to use, and we need to support the support of their supervisors, because they need to have the time to make this sustainable and on a longer term, and that they can work on this. So we learned a lot of this. We did it already on macro level, we did it on micro level, meso level, but maybe I have to tell you also that we had already also patient interviews. And in the intervention, we will also take the patient perspective with us for the intervention study. So I thank you for your